Hi everybody, my name is Paul Singh, an anterior segment surgeon out in southeastern Wisconsin in the United States. I'm here in Vienna at ESCRS, a beautiful city, fantastic congress, and I'm here to talk to you about a new philosophy, a new type of way of performing capsulotomy called PROcap. And you think about where we've come and how far we've come in cataract surgery, how more precise we've become, our predictable outcomes from our preoperative measurements to our intraoperative skills and technologies and precision. But yet, the last stage of that journey of attaining that 20 happy patient is the capsulotomy. At the end of the day, how we perform the capsulotomy can make a difference. We haven't seen a consistent approach to how we perform capsulotomy. Some doctors, 50%, will do a circular capsulotomy. 50% of doctors may do a cruciate. The size may be variable. And another pitfall that we also understand is that pitting is an issue. So a lot of surgeons are afraid of pitting, so the way we perform capsulotomies, it can cause iatrogenic floaters. Those iatrogenic floaters that cause patients to be unhappy as well. So PROcap takes a lot of the simplicity of a capsulotomy, but allows us more of a predictable, consistent performance. So what is a PROcap technique? The PROcap technique allows us to leverage the benefits of cavitation creation, utilizing a 2 millimeter posterior offset. Now, why is that important? Cavitation is created when a plasma spark forms, gas bubbles form. When we're far enough behind the lens, as the gas bubbles increase in size, they implode and cause a jet stream. That jet stream has properties that can allow us to also break that capsule. But because we're so far back, 2 millimeters behind the capsule, the risk of creating a pit is much less. Number two is because we're utilizing the benefits of the cavitation creation, so the risk of creating smaller pieces, those iatrogenic floaters, also decreases. And because we're not worried about pitting, we can create larger areas to remove the capsule. We can create nice circular, so the geometry can be even that of the anterior capsulotomy. So a large enough capsulotomy that has good geometry that limits the risk of pitting and iatrogenic floaters is really the main benefit. I think we're now in the age of premium IOLs, multifocality, extended depth of focus. And the properties of the lenses may be different in the center versus the periphery. So now more than ever, it's really important for us to create a large enough symmetric capsulotomy. And so this is why using PROcap and that 2 millimeter offset, allowing us for a larger disruption with each shot, gives us the ability to create larger sizes of the capsulotomy. I like to create the size of the capsulotomy near the edge of the optic, so I'm managing and really harnessing the benefits of the entire lens. So in my hands, in my experience, I'm much more consistent, much more comfortable, and less fearful of creating pitting in those multifocal IOLs, those EDOF lenses, and creating larger, more consistent capsulotomies with less chance of those iatrogenic floaters.